Good morning, everyone. The topic of the IC is Target 20 by Happy while providing freedom from glasses after cataract surgery, evidence-based. We have a large group of very experienced surgeons who will be talking to us about various topics. I call upon Dr. Mohammed Shabazz is not there. He's on the way. So, may I request Dr. Arvind Venkatraman matching the IOL to the needs of the patient, evidence-based. I request my co-instructors, Dr. Umesh, Dr. Kumaran, who else is there, and Dr. Shubodh Purohit to please join me on the stage. Okay. No problem. Also, I'll thank the Scientific Committee Chair, my teacher, Dr. Namrata Sharma, for giving us this IC at 8 o'clock in the morning.
Good morning to the full hall of chairs here. So, actually, the rules of selection for to make a patient 20 happy, which is the most important thing, has to be based on various parameters. So, I would like to look at ocular variations. We will look at lens-based variations. We look at patient variation, and then requirement-based variation, and surgery-based variations. So, most often when we think about how to select a lens, astigmatism is the most important thing that is being talked about. But true, but now with the advent of toric lenses, we can always correct the astigmatism with the help of toric lenses. So, it's not very difficult in a patient with planning for a trifocal or a EDOF lens. We can use astigmatic correcting lens to make sure that they get clear vision. But the most important thing will be the ocular surface, which is the most important thing which is often missed out, and other pathology of the endothelium of the cornea, which is often overlooked. So, the most important thing is please look at the ocular surface to make sure the patient has a clear ocular surface so that they get a good quality of vision post cataract surgery, without which a multifocal, a trifocal of a EDOF lens will misfire. The most important thing is look at the meibomian gland, if possible evert the eyelid, because most of the patients whom we are operating are elderly patients, and meibomian gland dysfunction is very common in our population. So, don't underestimate, if you use even a normal intraocular lens, the significant amount of higher order aberration created by the changes in tear film can make a monofocal lens laughable. This is a look at how much of tear film dysfunction can cause variations in clarity. So, if you look at the first picture with the normal tear function to a very severe dysfunction, you can see that the quality of vision drops significantly. When you look at this picture, this is the eye blink time. So, when you see the tear breakup time over a period of few seconds, you can see that the higher order aberrations increases exponentially. Actually, you will think that this may be a keratoconus, but it is not, it is a dry eye. So, what to do? Always look for the dry eye in patients whom you want to do any higher end intraocular lens, even a monofocal lens. If possible, treat the dry eye. So, if you can't treat it, better to avoid the trifocal lenses or a multifocal lenses. Make a good slit lamp evaluation mandatory in your practice, because if you miss these gutata or other endothelial pathologies, you might end up with a subclinical corneal edema, and then patients will say that the vision is not clear, they get more glares, they get more halos, especially driving. It becomes very, very big problem. So always the other factor to look at patient factor is the pupil size. So you can use a mixed match of lenses according to the pupil size. A patient having a higher pupil size will do better with a monofocal lens in the dominant eye and a trifocal lens in the non-dominant eye. Don't use EDOF lenses in people with a bigger pupil. So I will come to that later. So if it is a irregular astigmatism, it is a clear no-no for any of these refractive lenses. So when you look at the biometry, I don't want to emphasize that you need to have a good biometry, but one thing which I found was that never rely on a single formula. Even with this good high-end optical biometers what we have today, what happened to me was a patient whom the Barrett formula gave one value and the SRKT gave another value. I went with the Barrett formula because I was using Barrett formula only, and then I was in for a surprise. The reason being is, in that patient the Y to white was calculated by the measured by the IOL biometry was around 7 millimeter. So the Barrett formula gave a different IOL value for that patient, but when I looked at the SRKT, which is much closer to normal. So this is a very important point which I want to say here is, if you are using any optical biometer or any measure, please use two of the formulas, but it should be from different generations. The reason being is, though SRKT may not be as accurate as Barrett, but the thing is, it takes into value of few of the parameters, like Y to white and ACD is not a very big parameter in SRKT. So you will get a comparative value. So always don't get stuck to higher end formulas. Always look at SRKT also, just to make sure that we are closer to normal with any of the current generation, the second or third generation formulas. So in any patient or any eye, within patients, variation is the rule, as Darwin told. So what type of lens can be used for personalization in these patients? We want to give them glass-free vision. That means that 20 happy patients. So it's not 20/20 or N6. So the options are, don't throw away the monofocal lenses. It is mandatory to have monofocal lenses also in your practice when you want to do mix and match in patients with variations. So use of trifocal lenses is very important. Extended depth of lens, it's not like it doesn't have a problem. I will go to that later. No eyeballs is exempted. Selection must be tailored to each patient and each eye. So why not monofocal lenses? We have seen that so many patients whom we have done a PMMA lens or a spherical lens, they read very well, almost N8, and they have very good distance vision of 6.9, even 6.6 partial. So even a good spherical lens in a small pupil will make an EDOF laugh. EDOF is an exaggerated spherical lens. Remember, EDOF is nothing but an exaggerated spherical lens. So monofocal IOL, where I am using monofocal IOL, use it in a dominant eye when somebody is a vivid driver, they want to do all work at night, they have mild amblyopia in one eye. So all those patients will benefit from a monofocal lens in the eye which have these problems, or they don't want any problem. So either of these two. So when somebody says, I am not having so much of money, but I would like to have a vision that can both see distance and reading, don't forget to use the monofocal lenses, where you can think about giving them a good monofocality, where we can have one eye for distance, that's the dominant eye for distance, and the non-dominant eye for reading. So how to tweak asphericity? Asphericity is the one we talked about 20 years back, and now that we have gone back making spherical lenses in the name of EDOF. When you look at driving, it gives you a lot of power in terms of clarity of vision, especially nighttime vision. We can use a prolate or oblate corneas to select whichever lens you want to choose. If you want to choose a lens for older patients, Panoptics or a Technics or a Vivinex is better, but if it's for a younger patient, I find AT Lisa, which is the one thing which I use, seems to be better because it has a spherical value. And then when we come to drivers, we always think that EDOF is better. It is a misconception. EDOF is not better. We have to be very selective in EDOF. Many drivers and many patients feel the distance vision is blurred if you use a EDOF lens. So the key is pupil size. It is a mesopic pupil size of 3 millimeter. You can more than 3 millimeter. If you look at these presentations, you can see how different it is. This is a monofocal IOL in the multifocal in the left, and then you can have a EDOF in the right. So you can have lot of these glare which can be very different from multifocal. So it's not zero. So the EDOF patient also feels glare. So this is again the same thing. You can see the light here. This has a halo here in a multifocal. Again in the EDOF, it also has some kind of a glare and a halo here. Its only difference is the halo is slightly different. It's not predictable. It's not exactly what we see. You will get it. So that's the reason. This is another picture where we need to see how the EDOF performs. You can see that the EDOF tend to have the mesopic vision, the intermediate distance also drops significantly. So it's not like EDOF patients are happy with intermediate vision. And some of these trifocal lenses, you can see that the intermediate vision is good, the starting distance vision is good, and reading vision is good. If you look at this graph here, you can see that there is a great drop in distance vision with the EDOF lenses. Remember, there is a great drop in distance vision with EDOF lenses compared to even good trifocals. So we have to be very careful in selecting EDOF for a driver. So post refractive surgery, I would like to say that post myopic refractive surgery, you can use a more negative Q value like a panoptics. For a hyperopic, you can use a more positive Q value lens. So surgical considerations for being happy is precise centration of IOL, good phaco surgery, which I don't want to mention because it's all talked about. So especially centration is more important for EDOF lenses. The current generation trifocal lenses tolerate up to 1.5 to 1.8 millimeter of decentration. So complete decentration is very bad. Use of Purkinje images for centering as a guidance. So mine is all talking about thing. This is a very small thing. Whenever you put in a multifocal lens or something, you always try to center it and then always try to dial that. So always dial the lens to center it. Always make sure that the Purkinje images are at the center. Also, when you dial the lens, if this rhexis is slightly eccentric, align the haptic along the place where your rhexis is oblique. You can use this air bubble to see that the Purkinje images are centered on the IOL. So, and most important thing is, if you find that the anterior chamber is shallowing a little bit, it is always better to fill some air. This is very, very important in toric lenses and trifocal lenses because there is no post-operative shallowing. So, you don't get inadvertent, optic capture of the optic or little misalignment of the lens or a decentration of lens. You can always put in a little bit of air bubble. So, this is the only thing. And oblique rhexis, better to align the lens haptics along the oblique axis of your rhexis. So avoid optic capture until, that's why I am saying, like at the end of the surgery you can put a little bit of air, fill the air so that there is no decentration or optic capture. So conclusion is, don't pre-select your lens. Okay, somebody walking in, he is a rich patient, don't think that patient is a computer engineer, we are going to do this lens. So don't pre-select IOL before all the data in your clinic is available, because then only with all the data, as I told you, from the cornea till the biometry and what surgery you are planning, we can choose the best IOL for the patient. Always keep options open. Thank you.
Thank you, Dr. Arvind.
Yeah, Dr. Shanbas, a wonderful talk. Small practical problems when we in the OP. Sometimes patients come with a multifocal in one eye, done elsewhere, and you don't have what lens, and you don't know what type, what make, what technology they've used, whether diffractive, apodized, or old technology, or whatever. In that case, what is your suggestions in the other eye?
This is a good question. when we look at the lens as experienced surgeon, we will know whether it is at least a diffractive lens or a
most
EDOF
of them,
lens.
these
That
they
we
are
will know.
diffractive only.
So in any way, if they are happy, most important thing is they are happy with the vision or not. If they are happy with the vision, then probably I will do a say if it is a diffractive lens, I will do a diffractive trifocal for the patient, and maybe at the price point what they want. So if they don't want to spend much, we can give a trifocal Indian origin, or if you want to do it, they want to spend more, you can do a premium trifocal lens.
Yeah, I think that's important point, that first understand whether the patient is happy. First, what I ask is whether the patient is really happy with the vision, and in case they are so, you can put
Yes,
an
sir, we
alternative
can plan a
trifocal.
diffractive.
And another instructions mostly I give is ask them not to compare one eye and the other eye post surgery of the other eye, so that the adaptation, neuro adaptation will
Yes,
occur.
sir, that is always true with even monovision or a trifocal or a multifocal.
I think these 2 points very important when you don't know the what make is the other eye and patient still wants multifocality. If the patient is unhappy or complaining, or there is any residual refractive in the other eye, maybe you can go with a monofocal.
Yes, sir.
Yeah.
Thanks a lot, Dr. Arvind. We'll have more questions in the end. That was a very beautiful talk. Now we have the first talk, Dr. Mohammed Shabazz, choosing the right machine metrics formula to provide freedom from glasses.
Thank you, Dr. Elan, for including me in your course. This topic is very vast, like covering each and everything, so I will be quickly skipping the slides. So cataract surgery is no longer removal of the lens. It is cataract refractive surgery, where patients do not want glasses even for reading. So this is the crux of this study. So what gives us this confidence? So accurate IOL power calculation, advancement in IOL design, advancement in surgical equipments, good quality surgery with proper implantation of lens in the bag, and proper evaluation of the patient for comorbidity. So if comorbidity is there, we don't consider it for 20/6 vision. So IOL calculation, this is the basic of, if this is not correct, whatever good surgery you do, it is not going to work. So all these things are there, cryptometry, axial length, AC depth. Now in addition to that, all the newer formula includes lens thickness, effective lens position, white to white, and corneal thickness. Now here if you see, the effective lens position is the co-founder which is causing the problem. It's caused 35%. Other factors are there, but effective lens position is very important. So it has to be calculated. And what are the things required to calculate? You have to see the K value, axial length, white to white, AC depth, lens thickness, and then the IOL type also. Like when the IOL is coming forward or anterior bowing, posterior bowing, all these things you have to consider. And then as we're discussing, the rexis should cover the IOL properly so that you do not get decentered. So I'll just skip. So IOL calculation, it's very important to understand this. The 1 millimeter change will cause 2.5 diopter change in IOL power in normal patients. So if the eye is very long, then this will come down. But if it is short, it is going to jump. So we have to be more careful when we are calculating for hypermetropic or hyperopic eye, and always measure both the eyes. And if you get difference of more than 0.3, you should redo that, and you can ask the other people to confirm it again. So biometry, as you all know, we have ultrasound and optical biometry. There are many types of them. These are all. So contact, we are no longer using that. Most of the time we are shifting to the immersion one. Why we don't want to use that? Because the compression factor or in the fluid interface, because of these two, the axial length may increase or decrease. So in this slide you can see, this because of the compression, the AC depth has come down, and this has affected the axial length. So nowadays most of us do not see this, these things. Optometrists or technicians will be doing. So when we see all these things, then we can improve over that. Now here, if this is lower than the anterior capsular spike, then this proper alignment is not there. So immersion is still very important, because most of the time optical biometer cannot take care of hard cataract or media opacity. In that we have to come back to the immersion, and it has very good results also. This is a small video showing the immersion, how to do. The ultrasound probe is inserted into the shell such that the tip is almost 5 to 8 millimeter away. So there is no compression or fluid interface in between. Ask the patient to look straight with the fellow eye to fix at the distant point. If patient is one-eyed, you can ask him to look at the thumb and gently move the probe so that it is aligned properly to the macula. And the machine will start taking the reading. And then you can select the most common reading we are getting in that. So this is a beam you get in the immersion biometer. Here again, if the cataract is dense, you have to increase the gain of the machine. And if the aphakic patient is there or pseudo-aphakic is there, then you have to reduce the gain. If gain is too high also, then the beam will be merged. So here you have to reduce the gain till you get a separate beam in each. Here the retinal spike is not straight. So these are very minor things. If we see this, our biometry will be much better even with the immersion one. And if the beam is aligned with the optic nerve, then you will not get the scleral beam or. So this is like the advantage of immersion, and it is almost comparable to the optical biometer. The only thing we have to understand when we are using immersion along with like lens star or that, then you have to, the A constant will change because it will go up to the internal limiting membrane while the axial, this one is up to the retinal pigment epithelium. So optical biometers are highly accurate, non-invasive, currently gold standard, and I think first IOL Master came in 1999. Advantage, as we were discussing, measure till the Brooks membrane, while the ultrasound biometer measure up to the internal membrane, and the retinal thickness comes around 160 to 400 micron. So you have to guess this for even making the A constant for in adjusting the A constant. The precision will definitely be much better with IOL Master. So these are the few things when pseudo-aphakic, aphakic, staphylomas, silicon oil. In this you have to do adjustment in ultrasound biometer, while optical will be taking without this. So definitely optical will be better in that. So there are three types of optical biometers we have, and this study shows that there is no clinical significant difference between the three biometers. So all are good, but if you see this, the repeatability and reproducibility of swept source optical biometer was excellent, and agreement with the standard biometer was very high. Better lens penetrations, ability, and the IOL measurement, axial length measurement were obtained with the swept source biometer with the standard biometer. Now the cost factor is very important. So seeing the cost factor because swept source is very costly, so everybody cannot, and we are still the IOL Master and lens star, and they are giving very good results, so we can still. Now keratometry is measured the center 3 millimeter of the cornea. The important points we have to look into that is the average keratometry is around 40 to 50 micron. One diopter of keratometry change will cause almost one diopter change in the IOL power. Now hard contact lens nobody use, but the soft contact lens definitely you should remove 2 to 4 weeks prior, and should not instill any eye drops before doing keratometry. And keratometry should be done before axial length. Though these are different types of keratometry. This is very important when you are selecting the keratometry from different machine. The power will change according to the central area, how much it is taking. So lens star take around 2 millimeters. So here you can see the keratometry value is higher than the 3 millimeter which is taken by manual keratometry, 3.2. So almost 0.5 difference is there in this. So when you are changing the machine and using the other machine, adding, then we have to take care of this. Dry eye, as the Dr. Evid was talking, it is very important to look into the dry eye because it itself changes the cylindrical power. So now in this case, the same patient, the cylindrical power of 1.5, and after treatment it comes to around 0.3. So this is very important factor when you are going for higher end lens. The corneal irregularity is also very important. So if we have pentacam or
Faster.
Okay. So the aberration, like already the trifocal lens will have aberration, and if cornea is already having aberration, it's going to compound it. So we have to be careful with that. Now formula already we know. This is the every presentation we see that for normal case all the formulas are good, but in extreme cases, the Barrett's, Olsen, and nowadays latest formula Hill BRV are better in that. So Barrett's formula in this study was shown that it is better than the other one when they are comparing the IQ Alcon lenses. Well, this study Keynes seems to be most accurate. This is artificial intelligence based formula. But as the Barrett is easily available online, you can take. So we have to understand that when we are doing this multifocal and trifocal lenses, we should not rely only one formula. We can take 2-3 formula and then we take the result. This is a small video, like just to show the centration of the lens. I, being a cornea surgeon, I don't want to make too much port, so I make only one port for the entry. And I don't do cortical aspiration. So I will remove everything in one go. So what is behind this? So what I will do is I will separate the anterior capsule. This is one additional steps, but it's very simple, just one sweep. And when the capsule is separated, you do just a proper hydrocortical delineation, and now the nucleus will rotate along with the cortex. So it's moving along with the cortex. Now when you do phaco, everything will come along with the. So there is no cortical matter remaining, everything is done in one go. You can just implant the IOL. Rex's size is again important. We have to, if you want it has to be fully covered from all the sides, it has to be 4.5 to 5.5. Thank you.
Thanks a lot, Dr. Shabas. That was a very good thing, whatever you said. Immersion is almost equal to the optical biometer when done in the right hands. We'll have more questions in the end. Now I call upon Dr. Kumaran. While he prepares his slide, one more question for you. Of the optical biometers available, you said there are 3 categories. Which is your choice for a practitioner, not for a...
See, as this study shows, swept source is better than the other 2, but the cost factor is too high. So as an individual practitioner, I will not go for swept source. I will still be with Lenses Star and IOL Master. 500 is equally good. So there are some cases in which you feel that, in that we can do immersion itself.
Immersion. Thank you. Now, Dr. Kumaran will be talking to us about EDOF versus trifocals versus enhanced monovision, current scenario, and evidence-based. What does the evidence say? What we should use?
So good morning and a warm welcome to all. At the outset, I'd like to thank AIOS and Dr. Ilan Gumaran for this course. I think we have been doing this course for almost 3 years in a row now, and every year it's been getting better and better. Thank you. So my talk is going to be on advanced monofocals, EDOFs and trifocals. The odd man out here is the advanced monofocal because it really doesn't fit into the category of presbyopic lenses. But because these advanced monofocals have been doing very well and creating a lot of sound and giving comfort to the patients, this has really broken the shackles and come into be compared with EDOFs and trifocals, which actually being categorized as the presbyopic rating lenses. So I have no financial interest as any of the lenses mentioned here, and they're only for educational purposes. We have come a long way in which multifocality was first patented by Dr. Hoffer in the year 1982, and there are a lot of developments which happened in terms of the IOL technology and the materials that use, the property of these lenses, and the IOL designs. So each company plays into all these parts to bring in new technologies, actually all the same wine in a different bottle. So what they've really taken into account is the chromatic aberrations, the refractive index of these lenses have been played upon to give you different lenses of different technology. The IOL property, the material, the refractive index, the biocompatibility, the glass transition temperature, all these factors really play an important role in giving satisfaction to the patient and ease of the surgeon to implement them. I'm not going to touch into the basics of these multifocality lenses, but just a basic features of what a refraction is. The light deviates when it goes from one medium to another. A diffraction is a single point of light being split into multiple points, and the EDOF technology. The EDOF technology is making a lot of sound nowadays, but it's not a new technology. It has been used in astronomical telescopes and your SLR cameras long before we started using them. So if you could see all the lenses available in the market or the current scenario, these lenses fall into any one of these 7 categories. They could be refractive, diffractive, or combined. So when you offer these lenses to our patients, we basically have to think what gives them the best. So these are the different pictures of how an intraocular lens looks like. Even we are confused. Just imagine how confused a patient could be when you're going to offer these lenses to them. So the current scenario is when a patient is going to come to you and ask for spectacle independence, there are a lot of options available for these patients. The first 5 options are actually not to be used anymore because the bifocal technology is no more called the multifocal, and it has all been replaced by the trifocal. So basically the last 4 points, the 6, 7, 8, and 9 are the options which we can give our patients. An EDOF lens in both eyes, a trifocal, either refractive or diffractive, micromonovision with EDOFs, and micromonovision with advanced monofocal. So micromonovision simply means that you make one eye or the non-dominant eye less a little bit of myopic so that the near vision will be much better, and a dominant eye which is distant dominant. So basically, what are the limiting factors which really prevents a surgeon from choosing these lenses? There are 4 basic factors: dysphotopsia, biometric errors, cost of the implant, and demanding patients. And out of this, the reason why most of the surgeons do not implant a presbyopic correcting IOL is because of the dysphotopsia, glare, and halos. Now let's look into the literature, what it says by addressing all these factors. She shortlisted all the studies available in the last 10-20 years using all these lenses. So as you could see, different kinds of trifocals have been mismatched. All permutation and combination have been tried in one eye and both eyes. So these studies have implanted 3 different kinds of IOLs, the Panoptix, Atlaza, and the Epiphysiol. Why these lenses? Because they are the ones which were available in the market long before the other lenses started to come in. The only important thing to note that all these studies gave a good spectacle independence for all the patients, so all of them were very equal. So even the bifocal lenses, when you put in one eye and a trifocal in the other eye, all these patients did have a very good range of vision. There was no complaint with the visual acuity. Then these are another studies where they contribute the light disturbance or the dysphotopsia. But the only difficult thing is that the trifocals gave a very good range of vision, but however, because of the laws of contrast, they had a lot of reading difficulties when the contrast came down. So I had one of my patients who was an advocate who complained of inability to read his old documents inside the courtroom. So the trifocal lenses usually work very well, but you have to take it with a pinch of salt, saying that in dim light conditions, they do have a problem. And whenever we try to refract these patients, always make sure that you do a manual refraction and don't rely upon the auto refractometer, because they don't give a good values. And about the correct choice of the IOL formulas, no single IOL formula is best for a patient. Look at the patient eye and all the parameters and choose what IOL formula is best for this particular parameters. Then there's an interesting study which shows that a negative dysphotopsia is more in younger patient and shorter axial lens. So whenever you're going to implant a presbyopic correcting IOL in a younger patient with a shorter axial length, then you have to be really careful. You have to have a lot of chat time explaining the pros and cons. Contrast sensory loss is definitely there in all these lenses, but it is minimal with EDOF lenses and the when compared with the trifocal lenses. So this is another study which compared the angle kappa. So we all talk about the aberrations and the angle kappa, but you should know that the angle kappa, even if it is more than 0.5, doesn't cause any problem in the visual acuity of the patient. Even when you have a large angle kappa, these patients do very well as far as the quantity of vision is concerned. But when you have a large angle kappa, the problem is that they have a lot of dysphotopsia. So when you have a dissatisfied patient who's having a lot of dysphotopsia, go back and look into the angle kappa. You'll find that the angle kappa is more than 0.5 or the chord mu, which is a real technology now. So angle kappa, and the other important thing is that angle alpha could positively predict the outcome of near and distant visual acuity in these patients. So there's another study which showed you about the advanced monofocal in comparison with the EDOF lenses. They did a micro monovision and it was found that both of them are doing quite well. So this is the MDF chart which shows that in EDOF the intermediate is more prominent, in a trifocal all are good but to a certain extent, and in a bifocal the near is much better than the intermediate ones. So this chart actually summarizes, or the defocus curve summarizes my entire talk, which shows that all are quite good, but the enhanced monofocal, the depth of focus is not as good as the EDOF, but these lenses are very safe when you're going to look into a patient who's very demanding or who is an active driver or a younger patient. The trifocals give a good range of vision for all these distances, and they do well in a person who's going to confine to the household and just wants a spectacle independence for the daily routine work. So finally, it is best for you to understand the technology, understand the patient's needs, understand the patient's finances, and then choose what is best for your patient. Thank you.
Thank you, Dr. Kumaran. What is the experience in the enhanced monofocals? Especially, most of them we see they are within 0.75 residual astigmatism. Does that astigmatism 0.75 to 1, where you don't use a toric, what is the effect of the change in asphericity in the enhanced monofocals?
Yeah.
Are you seeing anything? Is it beneficial, or you can manage it?
See, to understand enhanced monofocal, the real terminology is they are non-diffractive spherical lenses. So usually any of these premium lenses, do not implant them when the astigmatism is more than 0.5 or 0.75. I keep 0.75 as the normal limit, because you really have to have a zero astigmatism for these lenses to work, because the presence of even a small amount of astigmatism is going to compromise the quality of vision. The patient is going to complain. And enhanced monofocal lenses, as I showed you in the chart, the depth of focus is slightly less when compared to the EDOF lenses. The only plus point here is that the dysphotopsias are very, very less. So if you want an elderly patient who wants to read somewhere in the intermediate range and want to have a good vision and should not have any dysphotopsias, then probably the enhanced monofocals do well. Certain patients, the young patients, when you implant the monofocal, they have a good range of near vision also.
Yeah, that's the pseudophocic accommodation to some extent helps. Yeah, I think up to 1, if you put a steep axis where you get a 0.3 correction of the astigmatism, say 0.75 residual, I think should be ideal. Thank you, sir.
Thank you, Dr. Kumaran. That was a beautiful talk, and that was in continuity with the previous 2 talks. Now I call upon Dr. Subodh Purohit. He's our keynote address speaker. Do's and don'ts in premium IOLs. Dr. Subodh.
What do you have?
Hello. Good morning, everybody. At the outset, I would like to thank
APO and AIOS Scientific Committee, Dr. Ellen Kumaran, sir. So today I'll be speaking on do's and don'ts in premium IOS. We have all seen regarding the trifocal CDOF and difference and this, what are the results of it, like technically and theoretically also, but how to select the patient and what we have to do and what we don't have to do in the premium lenses. First of all, I'll say that after the birth of your child, if most satisfying surgery after it is, I'll say it's a cataract surgery because it's a rewarding surgery as you provide a vision to the patient. Now coming to the do's and don'ts, we have to divide into the pearls, and we have to, our basic aim is to convert the premium IOLs and to a refractive surgery, not only to give the vision but to convert it into a refractive surgery. We have to divide into pre-op pearls, intra-op pearls and the post-op pearls. Now pre-op pearls, I'll say choosing a right patient is half battle won. Pre-op pearls, we can acknowledge the need of the patient, where the patient has got a need for near or the intermediate vision, understand is there any high level of concern for or a fear for night vision or related issues, as we know that the lenses with the rings will have some problems with it. Make sure that the patient understands that the neural adaptation is a process, and make sure patient has got a realistic expectations. There should be difference between selling versus educating the patient. This is the most important thing. We keep on saying this is the imported lens and this is so, the cost of lens is so much and this is the Alcon lens. Instead of that, we should educate the patient about the lenses. What are EDOF, what are trifocals, what are monofocals, what is monovision and everything. Now preoperative assessment will go for the ocular surface, TFM evaluation, rule out any ocular comorbidities. If at all patient has got any ocular comorbidity, avoid premium lenses in those. Avoid any anisometropic or high myopic or amblyopic patients. Then preoperative refractive surgery patient has undergone, there is increased propensity of glare, halos. There are challenges of power calculation. Recently we have witnessed for one very big celebrity in Bombay. Now role of OCT is very important. Being an anti-segment surgeon, you should go for the OCT even if the patient doesn't demand for it, or even if you feel that patient has got no retinal problems. And I'll like to stress that don't shy away to take the opinion of your retinal colleague if you're going for a premium lenses. And this is another important field. I'll say there is too much of information is confusing the patient. Just imagine if you're going for some cardiac angioplasty and the cardiothoracic surgeon tells you you want a medicated stent or a heparin-coated stent, and what you will say is, sir, whatever is best in your hand, just do it. And if you keep on saying all those things to the patient, like what is EDOF, what is asperic, he will get confused and he will land up with the jalebis. Nothing against any parties. Now measurement of premium IOLs, as Dr. Shehbaz sir has already told, outcome depends on multiple factors because precise preoperative measurements play a very important role. And role of advanced technologies help more for the perfection. Keratometry, we have to measure not only the magnitude but also the axis of the astigmatism. And since new formulas are based on all these things, parameters like axial length, AC depth and other things, lens position, we have to take into consideration. So the result, the point important for us is use the optical biometry according to your pocket budget. But still I'll say, even if you want to go for premium lenses, you should go for the optical biometry. Because already the previous speakers have spoken about it, like ablation, there is an error of 0.24 millimeter, and the least error is, I'll say, the optical biometry. Then appropriate formulas based on the axial length are very important, but nowadays Barrett Universal 2 is acceptable for most of the range of axial lengths. This is another important thing I use usually in my practice, that is triangle of agreement. I usually take 2 or 3 formulas and I use best out of 2. And if the patient has got severe astigmatism, I go for the topography also, and at least we know what is the steep axis and a flat axis. Then astigmatism in the premium IOLs, I'll say that preoperative corneal astigmatism, if it is more than less one diopter, I'll go for multifocal or EDOF lenses. If it is more than 1 to 2.5, I'll go for multifocal toric or the toric monofocal lenses. But if it is more than 2.5, usually I avoid EDOF, toric or any lenses with the rings.
Astigmatism, we have to take into consideration total astigmatism. Nowadays, it is not like desirable only to consider the anterior corneal astigmatism. You have to see for the posterior corneal astigmatism and also your SIA. Because if you don't consider it, if the patient is having with the rule astigmatism, we may overcorrect it by 0.5 diopters. If it is ATR, then we may undercorrect the patient by 0.30. IOL tends to center on the limbal center and not on the visual axis. So if the large angle kappa, we may have dissatisfaction of the patient in means of halos or the patient's poor satisfaction. Better option for such patient would be monofocal vision. And if you can afford, if you have got some such machines, if the patient has got higher order aberrations, you can use eye trace. Then needless to say, intraoperative pulse, like your incision should be perfect, rexis should be perfect. Nucleotomy, I'll say, even if the cataract is grade 2, if your patient is paying so much, use viscoat if you are in doubt for the poor cornea. And eye stability is one of the most important part. Eye centration, I like to add with the along with the previous speakers, you have to see the Purkinje images 1, 2 and 3. Purkinje image 1, where the bottom down, it is on the anterior surface of the cornea. Purkinje image 2, we cannot see on the posterior surface of the cornea. Purkinje image P3, it is on the anterior surface of the lens, it is just the reflection on the lens. And P4 is the Purkinje image 4 with the base upwards. So we have to coincide after the surgery P1 and P4 image for the proper centration of the lens. Now just guess, even after doing so much of gymnastic, patient may have poor satisfaction. So I'll say there are 6 C's for the poor satisfaction or unhappy patients, like poor cornea or ocular surface disease, cylindrical or residual refractive error, some capsular opacities, look for cystoid macular edema or other macular degeneration problems, check centration of the lens, or most of the point type A behavior patient like crazy patients. Leave those patients. Now negative dysphotopsia, especially when the pencil of rays comes from the periphery and the edge of the shadow lands up and we give the shadow effect on the retina, patient may complain about negative dysphotopsia, but in my practice I have seen after 2 or 3 months the patient get used to it, so we don't have to worry much about it. These are the positive dysphotopic phenomena usually we see in the multifocal lenses with the rings. Neural adaptation is just like your spouse, because it is both the problem and the solution. So the acquired process by which the nervous system adjusts changes to the neural inputs. The time taken is 3 to 1 or 1 year. So I'll say, if you can understand the Hindi, sir, खुद ही को कहते थे मुझे खुद को बदल लो, और अब बदला हो तो कह रहे कि वो ना रहे तुम. This is just like your neural adaptation. So rotational stability, as the IOL rotates by 3.3%, we lose the cylindrical astigmatism of the cornea more than, if it is more than 30%. Any disparity in the toric IOLs, you should, again you can go for fixing the problem with the www.astigmatismfix.com and we can realign the IOL. To summarize, start with the hypermetro female patients, know the patient's occupation very well, counsel the patient about halos and glare, especially with the multifocal lenses, precise IOL power calculation. The multifocal and toric lenses are very sensitive for the residual refractive error. Use newer generation formulas like universal Barrett 2 formulas. Avoid ocular extreme axial length or virial keratometries. Just straight away tell them that we want to, these lenses are not suitable for you, go for the monofocal lenses. And promise less and deliver more, otherwise this will happen. You may tell that I'll get more than 400 seats and you get only 288. Again, nothing against any party. Promise less and deliver more. And just imagine, after doing all the gymnastics, you land up with a patient having the glasses. I'll say few patients are there which we know are pseudophakic and wearing glasses and still they are happy. So nothing to worry about it. Go and use premium lenses in your practice. Thanks a lot. Thank you very much, sir.
Thank you, Dr. Subodh. Wonderfully put. Most of the points clearly explained. I think key takeaways, taking a history and understanding the need of the patient more important than all the technology that we have. So the next speaker is my dear friend Ellen Pasupati. Ellen is wearing many hats. He is now the president of Bangalore Ophthalmic Society, treasurer of Karnataka Ophthalmic Society, and joint treasurer for the AIOS. He is also the director of Navshakti Netralaya in Bangalore. He will be talking about advanced IOLs, firefighting and avoiding pitfalls.
Thank you. Thank you, Dr. Umesh. My topic today is avoiding pitfalls and firefighting in IOLs. All of us would prefer to have our patient with a clear, distant, and near vision. This is what our goal was 15 years back. But this intermediate vision of late has become very, very important thanks to all these gadgets that we are using nowadays. Most of our reading is on gadgets, so intermediate vision is very important. Despite using the best of the lenses, this is what I've been found, almost 35% of the patients develop either photopic or the need for glasses after surgery. And when we classify in advanced IOLs, advanced I've used the word trifocal, it can apply to EDOF or anything. These are the commonest problem that a patient says: glare, halos, starburst, poor vision, poor contrast. Now, if you try to classify these into poor vision, which are because of refractive problems, and all others because of photic problems, and you look at the causes, the commonest causes in both, most of them are common causes, but these two, dry eye and PCO, remain common in both the segments, while a calculation of IOL power is predominantly causes refractive problem, rest of them. And look at that last one, unexplained. That's what science is. We are not able to explain everything. Now, again I said, despite this is probably one of the best lens what we consider, and despite using this best lens, look at this particular place and this place. Almost 15%, 13 to 15% needed glasses, they were not happy with the vision. This is with a trifocal, one of the very good companies. I'm not mentioning their name. All of us use these things. Now let's get into the quality of vision. It's not the typical glare, halos or something we get. Normally we get a combination like what we have in the lower part. So, if there is an increase in the refractive error, just like what you see, definitely the photic components are also increased. The first take-home point would be then target emmetropia. And how do we target emmetropia? Very good slide which was put up by Dr. Mohammad Shahbaz initially. Use proper formulas. The best of the formulas are the recent generation formulas, Barrett and Hill RBF. Now the question comes, I don't have an optical biometer. How do I use it? Very simple. It's available online, free of cost. So utilize that. Only thing, use the ultrasonic, A constant or whatever factor that is for this. It's available free of cost. It's a large pool. It gets optimized every now and then. Next question. Simple thing. Very clearly it was elicited by my previous speaker, Dr. Subodh. Plano, you get very clear vision at all the three places. But look at just 0.5 cylinder. This is a simulation. What is happening? Vision gets affected. And this is very important in trifocals. I don't use the criteria 1. I use the criteria anything above 0.5 in these cases. This is not enough. Now, when you always use the toric calculator and look at this particular biometry. This is my Tomy optical biometry. Nothing wrong with the right side. I would prefer to use a toric IOL. Look at what's happening in the left side, which I have marked. Just shows 0.11. But when the astigmatism. But when the same thing is fed into a Barrett toric calculator, look at what's happening. It's asking me to use a T2. So, all cases, please use Barrett toric calculator, whether on your optical biometer or on the online, and then decide whether to use toric lenses or not. This is for advanced IOLs. I'm not talking about budgeted monofocal IOLs, if you are using advanced IOLs. The next thing that is done Yes, always do 2 workups, 2 machines, 2 observers at 2 different settings and 2 different formulas. If I keep doing this, patient will metastasis in my nearest clinic next day. So what I do is as soon as the patient comes, 2 formulas definitely we use, more than 2 formulas. On the day of when the patient comes to me deciding, I take a set of readings. As soon as the patient comes without putting any drops, and the second reading is taken on the day of surgery, most often 99% it matches. Very rarely there's a difference, which I explain to the patient, slightly delay the surgery, get the lens and get it done on the same day. Definitely I don't allow it other day. Problem with trifocals or any advanced thing is the rings, the dysphotopic effect. What do we do for that? Pre-operatively counsel them, tell them that they are going to have these rings. And intraoperatively, very clearly shown by my previous speakers, look for that centration. Look for that centration. Make sure it's on the center of the lens what you place, and then complete the surgery. Post-operatively, the patient is going to complain about rings, no problem. What do I tell here? If you are seeing the rings, that means this lens is working. Also remember one more thing, when compared to multifocal rings what we were seeing, trifocals is very, very less nowadays. Multifocals, I have even explanted lenses. Trifocal, till now I have not explanted any lens for dysphotopic phenomena. Refractive error, yes I have. Despite this, if the patient complains, this is the algorithm I use. If it is ametropia, either if the patient can manage with little bit of glasses, very good. Otherwise, either laser vision correction, or if it is a spirocylinder, rotated, decentration, corrected. But if it is that intrinsic problem, if it is a PCO, we can correct it. Anything in the upper compartment, well. Keep on counseling about these rings. Invariably, it goes off, very clearly shown by my previous speaker. 3 months to 1 year is what we say. Maybe 6 months as an average. Most of these patients stop complaining. If they still keep complaining, what I do is I prescribe the costliest possible lubricating eye drops. Finished. Centration of the eye, sorry, I'm going in the reverse direction. Sorry. Yeah. Post-op astigmatism, if it is a cylinder, if it is plain cylinder, nothing can be done. But remember, if it is a cross cylinder, say plus 0.5, minus 1, this is something that can be treated. Either way, enter your data on this, check whether it works, and then rotate the cylinder. If it doesn't work, yes, laser vision correction is possible. This is as a second option, we keep it. As I told you, photic complaints are very less with a trifocal IOL, more with a monofocal IOL, because that 16% of loss of light which causes this dysphotopic phenomenon is most of it is used for intermediate vision, hence there's only 4 to 5% cause of photic phenomenon. Despite this, it can happen. And look at these 3 things. If you look at the aberration, spherical aberration and coma are the common causes. Where do we check? I have a pentacam, so you check in this area, the total spherical aberration. That's the most common one. And then the better one, of course, is the eye tracy. I don't have it. If people have, you can use it. Pre-operatively, if it is above 0.6, then I avoid surgeries. If the higher order aberrations above 0.6, avoid surgery. The next is angle kappa, which my previous speakers were talking about. Very easy to find on advanced machine. It just means that the visual axis is not corresponding to the where you have placed the center of the lens. That's what it means. If you don't have all these in advanced fancy equipments, you can still, here the cutoff limit is on my pentacam is 0.21. If it is IOL master you are using, I think it's 0.5. I don't have an IOL master because it calculates at different places. So whichever machine you are using, use the correct measurement for you. In pentacam, it's called chord mu, and it is available. Now, here comes a state we don't have the advanced machine. You simply have an auto refractor. That is enough. All of us know that the visual axis is always nasal to the other 2 axes. So for your normal patients, keep on looking at it. If it is large, avoid an advanced IOL. Now this is one of the studies I wanted to deliberately put it here. They wanted to learn about predictors of photic phenomenon after trifocal IOL, and finally concluded that there is no such thing. It is only the more you charge the patient, more the patient is unhappy. Again, if by chance the patient develops a problem, we can use cycloplegic, recenter the lens, intrinsic problems, treat it accordingly. Last few slides, please. Counsel again repeatedly if he has. This slide has already been spoken by Dr. Subodh Purohit. It's not just by one particular thing, IOL power, Q value, or whatever it is, whatever the happiness is, a sum total, needs neuroadaptation, wait for at least 6 months, and finally hit this patient with all the investigations. Sometimes we don't notice this. This happened 6 months after surgery. Macular edema, cystoid macular edema, to a trifocal patient who was 6'6", became 6'9", 6'12". She was actually complaining of contrast loss, which I didn't realize, and then with proper anti-VEGFs and steroids, recovered. Finally, before you touch these patients, correct the dry eye. You don't have any advanced equipment, fair enough. Simple fluorescein is enough to classify these patients. Your autorefractor is enough to see the meibomian glands. Treat this patient as per this algorithm. This algorithm itself is a half-an-hour talk, so you can get this on ASCRS website. And final goal is to make your patients happy. Thank you once again for the opportunity.
Yeah, thank you, Ellen. I think preoperative counseling, postoperative counseling, or I would call postoperative reassurance more than counseling. It is preoperative counseling and postoperative reassurance to the patient, repeated reassurances. Thank you.
Thank you.
And there are now lots of report that says like we don't need to measure angle kappa, or we don't need to worry about angle kappa. And many of the studies have shown that with the current generation of trifocal lenses, decentration is acceptable, and so there is no need to measure the angle kappa, and we will get good results irrespective of even larger angle kappa like 0.2.
The 0.2 is fine, sir. That's why I put the value of 0.21. The problem is there are some patients with 0.5 also. I have some of those patients.
I think some lenses come with some lenses come with a larger central ring, and for them, I think the larger angle kappa could be tolerant. Very few of those lenses.
Yeah, it's very surprising, you see. The multifocals, they say, the very happy patients are the hyperopes, and angle kappa is high in hyperopes.
Correct.
Definitely.
Somehow I'm not able to get that. Maybe Arvind's answer.
No. The thing is, when I was doing for this presentation, I found like there are many studies which have done angle kappa and patient happy
Yeah.
at the end of the day.
Multifocals are very good in hyperopes. That is proven. So hyperopes have angle kappa. So that means the theory is matching. Okay.
Now we have Dr. Umesh, head of Shankara Eye Hospitals, Bangalore. He will be talking to us about tackling astigmatism in cataract surgery, evidence-based.
Thank you, Dr. Ellen, for these wonderful topics and most practical-oriented topics this way. Now, all of us know that astigmatic treatment is part and parcel now, especially because we have entered the zone of refractive cataract surgery. So, astigmatism correction makes important part of our practice profiles. So, what are the different modes here is, these are the different modes. One is intraocular lenses, that's the hallmark. Now you have flax, it uses the femtosecond technology for this. The only challenge is it's more costly. LRIs and PCRIs were always there, but because of regression and unpredictability, it somehow is losing its credibility. And post-surgery custom ablation is one option that we have for the unsatisfied patients. And the emerging technology now is the intraoperative aberrometry, which does the real-time phakic and pseudophakic refraction and gives feedback. Now, as my previous speakers have all re-emphasized and emphasized, for any astigmatic correction, two things are very important. One is the amount of cylinder, the value of the cylinder, and the axis. These two are important. And invariably, we have all these equipments. In my thing, I always see a variation in each of these. So that is where you have to use your trial, your error, your validation, your calibration, and ultimately your experiences, and try to find out which is the best for you amongst the available resources. The best is you take 2 readings of different technologies. If you have a swept source, you do also topo with a sham plug, or the AR, which is a different technology, and try to get. I somehow have come to a conclusion that the cylinder amount of value of cylinder, if between the two is less than 10%, you take. The second is the axis, because I go for the automated top cons because I do refractive surgeries, I get good results with that. So I prefer the axis there. So I believe all of you should try to do some trial error from your perspective of the data that you get, do some data analysis and can come to some conclusions. And of course, posterior corneal aneurysm now is imperative that we use it. And previous speaker has already told that under correction, over correction, especially with the rules and against the rules, we are part of it. Now, this portion, this 0.3 up to 0.3, it is there. There are some cases where you get minus 0.3 or 0.4 or plus 0.4, 0.5. There you have to make that necessary corrections. Otherwise, if you tick the box PCA, it will take into consideration. And the most important is the marking. Once you know what is the axis, once you know what is the amount of cylinder, comes the marking, and that is where most of the deviations occur for us. And there are many things here. One is standard markers, the bubble markers, and yes, all of us have been doing it. We have our own variations, our own standard deviations, but again you have to develop your own. Let us discuss some difference between the image guided and the manual markers. The bubble marker effectively is better because you can at least see the orientation. There are many advanced markers also, manual markers also. But the disadvantages, yes, there are some disadvantages here. Smudging, especially when you are using the ink. The thick ink smudging often leads to 5. That is our threshold. The 5 degrees is our threshold. That is where you end up. So you have to ensure. Now thermal dot mark ink marks are there to prevent smudging, and or some of us, most of us, at least I have now stopped using the inks. We use the 27 gauge needle to do the marking. And image guided techniques, they use the Callisto and the Virion. They are the most commonly available, expensive, but they are now help us to avoid these things, the errors there. But it also has its own problems and disadvantages. People who use it will definitely know. And the eye tracker disengagement during surgery, it requires re-registration. That becomes very problematic. What is 5-minute surgery will become a 10-minute surgery there. Conjunctival chemosis, bleeding interfere with intraoperative registration. Registration may also be not possible, especially if the patients are uncooperative, and most importantly, the high financial costs. So each of them have their own pros and cons, and of course, the future is the intraoperative aberrometry, the ORA. At some point, we will all have that, and that is the principle. Now, let us do what is the comparison, because we have to come to a conclusion whether manual marking, or because that's the most important aspect, manual marking or digital marking. So Shirish, my friend Shirish Kudavur, he did a study between manual and he said the results were comparable. Ding and the latest one, he has compared between the both, and he said that he made a small variation on table using a 26 gauge needle directly at the axis, not the horizontal or vertical, direct the axis, and he said that improvised his outcomes, and the manual and the digital marking to some extent matched, and there was no significant difference, especially when they went for the mean deviation less than 5 degrees. Both were well within less than 5 degrees. So very well accepted. Course B also was there, and the one which is TTL sir, comparative evaluation of the 3-step marking with the conventional, with the image guided surgeries. He also showed that the limitation of the study obviously was that they didn't take into consideration, they only took the rotation, not the residual refractive error. But even if you look at the rotation stability, it was comparable. So I guess people who want to do marking, if some experience, some trial, if you are able to get the correct ones, I think you will get more or less good results comparable to the image guided lens. And what I do is this, I use a slit lamp slit, Most important, ensure the patient is aligned vertically here, the patient is aligned vertical, and the split is done horizontally, then you know that you are perfect 90. Now I also do the vertical axis similarly. The difference here you see the smudging between the 90 with this one and the smudging occurs, and so what I do is mark it and then do the smudging, or on table put a blue, so visibility becomes much effective. And intraoperative axis, obviously, once you do that, you do the intraoperative. Even in intraoperative also I use the 26 gauge needle, and that gives me more less than 5 degrees of efficiency there. And rotation, on table rotation. Anybody doing torics, I believe that this is a very good paper. All of you must go through this paper. It's a comparison of the rotation stability of two toric intraocular lenses. The main ones, the J&J, Technis, and the Acrisoft, done by Dave Chang. It was the largest series, 12,073, and very beautiful key takeaways that he has given here. First is the thorough irrigation aspiration to remove all OVD. Yes, all of us emphasize that, including below the IOL haptic and capsular pharyngesis, most important around the haptics. So these two things, because most of us just tap and remove, go behind the IOL, go beyond the capsular pharyngesis and around the haptics. Proper inflation of the anterior chamber to ensure the TIOL rests on posterior capsule. I think my previous speaker told putting air bubble also, and that also aligns with that. Greater axial length, and with the rule astigmatism more likely to rotate, especially greater axial because the bag is larger. So nowadays I am using rings also just to prevent rotation. Maximum incidence of rotation occurs within the first hour of surgery. So what they recommend is limit the patient activity to immediate post-operative period. They ask them to, especially if you're doing topical, patch them, ask them to lie down, not move for 1 hour to prevent post-operative, because maximum rotation occurs within the first hour of surgery. Rotation stability depends upon material, width, stickiness, design of haptics. They said that the Technis IOL rotated more than Acrisoft, and because of that the Technis J&J came out with a modification of the haptic with those sandblasted haptics, and now I believe they are also doing well. I think these are all the feedbacks that we get from them. And in case of repositioning, if there is any rotation and you want to reposition, they recommend delay the procedure for at least 2 weeks, as capsular contraction will occur and it will prevent re-rotation, because further re-rotation, and use BSS on a cannula to form anterior chamber instead of OVD during the procedure. Just to emphasize, cleaning the OVD behind the IOL, in the capsular pharyngesis, and to me, I see depend on the thickness of the IOL. The Alcon types, where the refractive index is on the higher side and thin, it opens up faster, where the Technis opens up slower. So wait for the haptics to completely open, spend 1 or 2 times, then rotate and then stabilize the patient. See, that would be my key takeaway to ensure that you get good successes. Thank you.
Thank you, Dr. Umesh. That was a very good talk. Any idea about the cheaper, I call upon Dr. Subhash Prasad sir to get his slides done. Any experience with the cheaper non-marking devices that are available in the market? I just have one, that's why I asked.
Yeah, the slit lamp, the camera-based.
Camera-based.
Yeah, I don't have any experience, but I'm very happy with this slit marking with a 26 needle, both horizontal and vertical. Just the one thing is make sure that the patient alignment is correct. Sometimes what happens, patients tilt their head and you get a slight 5-degree variation. So make sure the patient is comfortable, holds, and his head straight, and then do the marking. I think there you can manage some of the.
I have one slight variation. So usually if the axis is say 160 or 170 or 180, I always try to do the surgery on the steep axis. Say if it is 160, I mark the 160 axis, I do the surgery on the 160 axis, and when we do that, the placement of IOL will also be on the 160 axis, because there is no difference in astigmatism created by our incision. So I don't need to mark 0, 180 and then the vertical axis. I just need to mark only the axis on which the IOL is placed. On the same axis, I do the cataract surgery, and the lens will be placed on the same axis. So that's how it will be.
Dr. Arvind, I also do the same thing.
Yeah,
the
that is
only
what,
problem happens when it is nasal. So nasal we don't go ahead. So what I do in those cases, go a little bit temporal and create the side port there. So that side port is going to guide us. But what OCCI, something like that. So do that and do it. Anyway, there is a what I wanted to mention. An Indian innovation is there. There are a lot of almost 3 Indian innovations which are your smartphone based, which can be used in the OPD. Jetwa marker, Patwardhan marker, and recently Dr. Shishir marker. This last one, what I want to tell, he has extended it and taken it inside the OT. For a very small amount, you can get that device and use it in the OT. Despite these 3 things being available, single mark is required. You can mark it anywhere, but it will calculate what that axis is. Need not be 0, 180. You can mark it anywhere, and from there, your phone will calculate what is the real axis, and it will show you inside the OT. Beautiful one. It's available in 3D Medicine stall. You can see it. No personal, financial commitments from my side, but I was really impressed with that when I saw that.
Yeah,
Yeah, even
the more you use, you yourself will get more ideas.
Even Dr. Swapnil Kothari, one of my
Swapnil,
friends.
sorry, not Shishir. Dr. Swapnil Kothari.
Swapnil Kothari, yeah, I use that. And that doesn't cost much also, because not usually we just go with the street lamp marking as 0 and 180. We mark it with the this blue, gentian blue or anything. We send it to the server. That server will calculate and tell us whether we are marked perfectly or not. If it is -3, like it is less 3, we just have to keep on the table on the same axis which he has provided, just for the accuracy or reconfirmation. And believe me, it's bang on, and it's free of cost online.
So, yeah, it's
Free of
free of
cost
cost
online.
online. But if you want the inside the OT marker,
Marker.
that is
You have
slightly,
to, just like a video. He's coming with the.
it's already come out. It's there.
Yeah.
Is it?
Yes.
Yeah, I think innovation. Otherwise, we can't keep spending money on.
We
these
can't go
things.
for every time video and other things. We can't afford that.
Now, Dr. Subhash Prasad sir is a teacher for my teachers. Thank you, sir, for coming here. He'll be talking to us. We have did all these things, but there is a residual refractive error. So how do we manage that? Management of residual refractive error or refractive surprise, evidence-based. Thank you, sir.
Thank you, Dr. Allen, for including me in this course. The history of intraocular lens dates back to 1949, when this gentleman first implanted the lens, but he had a huge refractive surprise of 21 diopter. We understand that the technology and everything was very primitive at that point of time. So with the advancement in technology, not only the machine which could calculate the intraocular lens very correctly, but the IOL formula and the machines which we are operating upon, and the training of us led us to become a very proficient surgeon and to give a best outcome to our patient. But no matter how, whatever you do, there are some situations where we get some refractive surprises, which can lead to dissatisfied patient, particularly once you have implanted some premium lenses. So all precautions has to be taken to prevent its occurrence, as well as to diagnose and manage it effectively at particular point of time. So prevention requires more consistent method of biometry in intraocular lens formula. So I won't go into that detail. It has already been dealt with. But one most important thing is prior refractive surgery. I do get some patients referred from here and there who had undergone some LASIK procedures and now came with the intraocular lens implanted with refractive surprise. So another important things which I have noted, that there are sometimes typographical error which can lead to postoperative refractive surprise, particularly in the toric lenses, where the person has actually put the data 90-degree opposite to that. There can be some IOL mislabeling sometimes and wrong IOL in wrong patients. So what to do once we encounter these situations? You must look for the cause, what went wrong, check all the data, and in the immediate post-op days, we can sometimes find capsular back distension syndrome, particularly in the plate haptics IOL. So you have to dilate and see whether there is any fluid behind the lens or not. And in RK patient, you have to actually wait for the refraction to be stable. So what you are going to do, if the patient you have to know what is the patient expectation. Sometimes patients may be happy, but you are not satisfied. So don't let the patient be unsatisfied by telling that you have this much of refraction, which we did not expect. So if the patient is asymptomatic and very much satisfied, just simply observe. If the patients are ready to wear the glass, small amount of some refractive surprise, give the patient a spectacle, and contact lenses if the patient is used to and if there is high degree of anisometropia. And there should be frank discussions with the patient regarding the source of this error, and once it is known, how to correct it. The patient who desire actually spectacle independence, discuss them the risk of the further surgery, because sometimes there may be some chance of losing some vision, particularly the risk of infection is always there. So they have to be told about the risks which are often greater than the primary surgery. So there could be two ways by which we can correct this surprise, like lens-based approach, like IOL repositioning, IOL exchange, piggyback IOL, and the cornea-based approach, that is the laser vision correction. So IOL repositioning, particularly in the toric lenses, I have hardly re-rotated the patients in the normal cases, but I have rotated in 3-4 patients where the data was actually misfed and the 90 degree in the opposite direction. But it can happen, so one has to take all the precautions, and it has been rightly dealt by previous speaker how to take care of that. So the advantages of the lens-based approach is that original cataract wound can be opened and you can go through that, and there is high degree of spherical aberration which cannot be corrected by the LASIK procedure. You can do with the lens exchange, and it does not alter the corneal architecture like in the LASIK. At the same time, there is no need of special settings. So one can very well do that. So in IOL exchange, if the problem is significant or the problem with the IOL, and these patients can be subjected to IOL exchange, but again, it is less predictable than the piggyback and the laser vision corrections. And the chances are there adhesions, strong adhesions in patients who are coming late. So in those patients, you may not be like to put that lesson. This is one small video clip when it is quite old, more than 20 years old, when I this was my first RK patient who had developed actually cataract and came to me, and I did not have much idea how to go deal these patients, so I landed with the refractive surprise. After having waited for 2 months, I explanted the lens. Since the number of incisions were less, so I could go through the limbal incision, otherwise I could have gone through the sclera. So this was one situation. Another very interesting situation, that one of my patient who wanted to go distance free intraocular lens implantation landed with the surprise of 5 degree. And when I reviewed what went wrong, I could see that the patient actually, this is the IOL Master 700. Patient was not actually focusing. You can see the tilt, so the graph was not good. That's why the patient had calculation of the axial length, which was much less. So when I did that, you can see the IOL here. The actual axial length was actually less, so more. So I had to explant this lens and then put a 10 diopter lens. This was a toric lens implantation, and before this time I did not have Callisto, so I was using the manual marking. So once you are planning to do IOL exchange, you have to inflate the capsular bag and the anterior chamber, good viscoelastic, viscodispersive. I prefer using viscot so that you don't injure the endothelium. Then disengage the lens from the capsular bag, take out into the AC, and what I do that I implant the next or the desired lens in the bag before I take out the lens, so as to give a scaffold to the lens and to prevent the posterior capsule by abundantly injuring with the vanas or any other scissors which you are using to cut the lens. So here I am just rotating I have rotated the lens and taken out in the anterior chamber. Now I am taking out the haptic and holding the haptic. I am again using the viscot. I am using the Osser cutter. You may not need to go complete, even half. If you go to half distance, it will roll out the lens through 2.8 or sometimes 3 millimeter of incision. So this is one of the method of taking out the lens, that you need not cut it completely. So another option is the piggyback lens. When the surgery has been quite long back, and there is strong capsular adhesion, and you think that there can be more injury if you try to free the lens from the capsule, then it's a better option. So it's effective, safe, and easy. Here you implant a lens into the sulcus, over and above the posterior lens, chamber lens, which is all there in the back. The only thing is that it sometimes can cause some pigment dispersion or other things, but the Indian lenses are available from the care group. Don't have any financial interest. And the power of the piggyback lens, it's easy to calculate. If there is hyperopic error, you multiply the lens spherical equivalent with 1.5, and for myopic error, is multiply it with 1.2. This is one small video clip. This was 30 years old made. Actually, this was a case of pediatric cataract which was done when the person was 10 years old. Then he came to me with so much of the refraction. The same thing can be extrapolated actually in the adult onset cataract surgery with refractive surprise. This is one of the Indian made lenses, add-on lenses, came by the name of Sulcofix. The prototype is Sulcoflex from the Renner. So I have no experience of using that. This was a toric. So its implantation is very easy. It doesn't take much time, and this patient had actually YAG laser also done. So that is the advantage of using piggy back lenses in situations where you already have posterior capsular dehiscence or any PC capsulotomy done. Then this is a better option than going for the IOL exchange. So laser vision correction is another good options, but it can be reserved for a small amount of refractive error, but it requires extra machines and extra cost. So if you have this machine, you can offer to your patients. PRK is preferred over LASIK because here, since most of the patients are old, so it doesn't compromise with the tear film. But if you are doing this, better to wait for 3 months, let the wound stabilize. And there was just one study which clearly said that the LASIK is the most accurate procedure to correct the residual refractive error after cataract surgery. Of course, it cannot go up to very high, and you have to see how much the cornea, the thickness is there. This was one of the 43 years old female patient operated 2 years back with vision of 660 and had a refractive error of this much. So since the corneal thickness was very good and patient agreed to go for the LASIK procedure, so I resorted to this procedure for this patient, and patient was very happy after the surgery and could achieve 6/6 without any problem. So that is one of the best way of correcting, giving almost 6/6 vision to this patient. So just to summarize, refractive surprise can occur no matter how much careful you are, how much new machines you use. Particularly in predisposed eye, look for the cause. Give the options of using glass and contact lens. If they don't go for that, then you can use these procedures to correct the refractive surprises. And IOL exchange piggybacks are reserved for the big surprises, but you can go for the laser vision correction for the small refractive surprise. Thank you so much.
Wonderful lecture, sir. So I would like to ask, many times when we get the lenses for some toric lenses, for example, like 21.5 diopters, and it shows residual refractive error would be plus 0.25. In some, if we get 20.5, we get minus 0.25 or 0.75 of the refractive, because we don't get in odd numbers. So what would be your choice for toric lenses in like residual refractive error of plus diopters or in myopic diopters?
Sir, actually, we expect that there will be some amount of, by definition, refractive surprise is told once you have 0.75 diopter mode of astigmatism after surgery and 1 diopter of spherical after surgery. So, I could not get your question, how much you?
No, sir. For example, if like lenses available for you, for example, they give we calculate and we send the patient for some calculations, and if they say that with 21.5 diopter you will have residual refractive error for such patient like minus 0.25 diopter in plus, in minus, and with 22 diopters it will show plus 0.25 residual diopter. So what would be your choice? Whether you'd go for the myopic residual refractive error for that lens, or
I would go for myopic.
Right.
I think what we can do is we can type of refraction. Young patient with the rule go to the plus side, and old patients against the rule, because you don't expect much changes going forward.
Yes, very
You
true,
be on target. Whatever the least astigmatism, you go. But young patients with the rule, you always have to go to the plus side, because after some time the ATR kicks in. As you age, the ATR also kicks in, so that will to some extent neutralize that.
And also, I think minus refractive error or residual refractive would be better tolerated as compared to
Yeah, that's okay.
hypermetropy.
These with the rule, young patients I think going to the plus side.
Plus side more.
Yeah, agreed, agreed.
Yes.
One thing,
I agree with the minus part of it. The reason is if you go to the plus side, it will flip the axis. That patient is going to be very unhappy.
Unhappy.
Very unhappy. Little bit lesser is little bit.
one thing just I want to mention that in RK patient who had developed this postoperative refractive surprise, piggyback lens is always better because here you can calculate the power and if you just exchange the lens, even then you are not sure how much it's going to be.
One more innovation I want to add, sir. Dr. Neha Dolakia has brought about
Yeah,
a lens cutter.
Yeah.
Beautiful. Just 12,000 rupees. Indian innovation. Chamber doesn't shadow.
Yeah.
We need not have to use the
No,
scissors.
I have stopped using this saucer.
Yes, sir.
Yeah, ultrasound tip, no?
Ultrasound tip. Ultrasound tip.
It will solve major problems. The next talk and the final talk is Dr. Ellen's using spherical aberrations to our advantage. Dr. Ellen?
Thank you, Dr. Umesh. Just when I'm talking, the person who taught me about spherical aberration is here, Dr. Rohit. Thank you. We'll just take a little bit of, he was the one who inspired me to get into this. And it was in 2008 or 9, sorry. Slides. ये डाल दिया अच्छा slide show. Okay. I've actually slightly named it right IOL for the right patient how to choose, of course, using the spherical aberrations to our advantage. There are two things we have to look at. Patient might ask for a 1.5 lakhs or 2 lakhs best possible laser refractive surgery, all these things. But what we should look at is his wants versus his needs. I want to make this very short. We are already running short of time. As I told in my previous talk, look at coma as well as spherical aberration. Here we are concentrating on the spherical aberration and look at that in between value between 0.136 to 0.57, approximately 0.6. You can put any kind of advanced IOL. The patient will tolerate. Of course, look at all other problems. This is only with spherical aberration. This is a slide. It took some time for Dr. Rohit to teach me. Now, what is a spherical aberration? What are we looking at? The eye is not a perfect sphere, right? So, eye is like a parabola. A parabola corresponds to around 0.53, whatever that reading is, 0.53 minus. Now, this is what we take as zero spherical aberration. Where do we look at? Just like what I showed in my previous slide. I have a pentacam. I look at the spherical aberration there. A better thing would be to use an eye tracy like what I said. Anything above 0.6, avoid all advanced IOLs. It's not just the IOL that provides vision to the patient. We have also already in the previous talk, we have emphasized there are a lot of things. One of them happens to be the spherical aberration. And herein, I would like to bring in what Dr. Uday Devgan, I have given the credit to him. This is from his slide. If it is a virgin eye, then all these things will work. If it is already an eye which has undergone LASIK, particularly this prior hyperopic LASIK, never go for this negative spherical aberration lenses. We have used the traditional IOLs, then we came to negative spherical aberration lenses. Do not use it in case of hyperopic LASIK. If you measure the spherical aberration, you will understand why. We'll come to that later. Now, if it is a myopic LASIK, just like how one of my previous speakers, I think Dr. Venkatraman was talking about it, you can use a spherical aberration lens. In case no prior surgery, and then look at IOL decentration, whether there's a chance of IOL decentration, such as pseudo exfoliation or some other thing, then prefer a spherical aberration of 0. There are lenses available, we'll come to that again. Now, if IOL centration is not likely to occur, then you look at the other options that are available, where depth of field, that is multifocality or whatever you call it, or image quality. For this, I have a couple of other slides, we'll go there. Okay, taking it from there, considering this no spherical aberration, what is the right thing for a patient to have? What should we leave it with? Either it can be slightly, human cornea is always positive. That's why we have this lens which is on the negative side, which slightly neutralizes, but as we age we all know this, that's why we use these negative aspheric lenses. But then how do we calculate this? If the total spherical aberration target is 0.2, what do I mean by this? The corneal spherical aberration added to the spherical aberration that you have with the lenses. Whenever I look at the lens, I don't look at the A constant alone, I look at all these other parameters. I ask the lens manufacturer what the spherical aberration of the lens is. If you get this target, the patient is very happy. Now I have written on the image quality side. Sorry. Now, if the spherical aberration, total spherical aberration goes beyond this range, that is 0.5, 0.6, this is called toxic. Avoid any of the advanced IOLs in these cases. If it is somewhere in this range, that is prior hyperopic classic, use the traditional spherical IOL, and again if it goes beyond that, this is very rare to get it, then again traditional spherical IOL, but again we want that this patient might need some other corneal procedures. Now what are the two values that we have to take home? One of them I said, if it is image quality what you are concentrating, leave this patient with the spherical aberration of 0.1. That is, you are using a trifocal IOL, you are using some kind of spherical aberration, look at the cornea, do not go by the company, look at the cornea, look at the spherical aberration and match it to this. This is what I am doing off late. I have 3 different trifocal IOLs. Now, if it is a depth of focus you are looking at, it's a poor patient who cannot afford, even with monofocal, you can give some kind of depth to this patient. This is what all these enhanced monofocals are doing. So look at the value of final 0.3. So how do we calculate this? Sorry. Yeah. These are the options available in my clinic. It could be a 0 spherical aberration, positive spherical aberration, 0 spherical aberration, minus of 0.19 or 0.2, and the highest what we are getting as of date to the best of my knowledge is minus 0.27. I am not talking about the brand of the IOLs, obvious reasons. You know what 0.27 is, what 0.2 is. There is one at 0.18, there are certain at 0. So look at the corneal aberration, add it to these values, and if you are looking at good quality of vision, target should be, this addition should land at 0.1. If you are using a monofocal IOL and you want to give some kind of multifocality to this patient, target 0.3. Simple mathematics, but you need a pentacam, or I use a pentacam, but better would be an eye tracy. Eye tracy is obviously the best, I don't have it. Now, we have various occupations who may require intermediate, but this said and done, whatever, when you calculate the spherical aberration, this is only for intermediate distance. Near vision, again need for glasses. Anyway, I don't assure these patients freedom from glasses. The monofocal IOLs where I do these changes, I don't assure them, but definitely many of them are doing well. Even the well established who go for monofocal, there are a lot of hobbies that need near vision. This is a similar graph which was projected by Dr. Kumaran. Anyway, each lens has its own. Summing up, we are running out of time. I am slightly fast forwarding my slides. Look at wants versus needs. Rule out all other pathologies. If there's a pathology and you put an advanced IOL, this patient is not going to be happy. Look at the non-dominant eye, that's where you do, okay, with all this spherical aberration, you still need to do a little bit of an offset. Non-dominant eye, do a little bit of offset. Rule out aberrations. Communicate to this patient. Always you will be a happy, 20 by happy patient. At the end, thank you. Thank you, Dr. Rohit, for teaching also. I like to thank Dr. Amrita Sharma and then all our esteemed delegates here who attended this despite having it at 8 o'clock in the morning. Thanks a lot, sirs.
Wonderful lecture, so wonderful. It was really a learning experience for us.
Thank you, Ellen. I think we are behind time. Can we close this session?
Yes.
Thank you all.